I'm excited to introduce our next case study with Andor. Mary Morin is the Chief Nursing Officer at Andor, and Noel, help me.
Khirsukhani, yeah.
Khirsukhani.
You had it right.
Is their Chief Growth Officer, and I will hand it over to them.
Yes, so much. Thank you. Well, I want to first off thank Microsoft for inviting us over here today. This particular session is really about Andor Health, who we're going to talk about. In particular, I think what's going to be nice about this conversation is the fact that it actually leans on the last panel discussion around the practical use of AI, particularly in a clinical setting, and seeing how return on investment actually is driven by these organizations and how they think about that specifically. Now, with that being said, one of the first areas that I want to make sure we take a moment to think about is maybe a little bit of a reframing of how we think about AI. I think what we heard from the panel earlier were some incredible points to kind of be considerate of, but there is a higher level discussion that is ongoing in this industry. There's a lot of AI that is out there. There's a lot of confusion that is also out there. There's also a lot of where do I actually leverage certain capabilities? And right now, as we work with, somewhat of about 40 some odd health systems in the United States, we're learning that many of them are still trying to figure out what is their journey, what is their strategy in AI. And when you have, for example, technologies that are feature-based in terms of AI, and then on the other end of the spectrum, you have hyperscalers that are bringing horizontal-based AI, large language model capabilities. How do I actually marry the two? Where is the middle of the road? How do I actually leverage and plug into a specific infrastructure that allows these behaviors to be composable? When we started working with organizations like Andor, as you see here, that was a common question for many of them, is I don't want to have to acquire a specific AI feature that lives on its own, because healthcare doesn't work that way. Healthcare works in context. So while I have this, does that mean I have to go and acquire another AI technology to manage workflow, to manage this particular use case, and try to ultimately plumb it all together in some way, shape, or form? That, and I think the earlier question was, how do we create scale out of that? We fundamentally believe that what is needing to come to market is more of an infrastructure to allow these AI capabilities to drive the last mile. When we started this business, Andor Health, back in now 2018, we had a very unique opportunity to work closely with Microsoft. We became enamored with some of the investments they were putting in OpenAI, ChatGPT, and even this little thing called Microsoft Teams. We thought to ourselves, instead of somebody actually starting a team session, what if you could have an AI agent or a bot that could start that session? What if that bot knew that this particular nurse is assigned to these particular tasks, has this particular event, needs to meet with this patient, and here's the content and context that is required? And when I actually join the patient in a session, what if I could actually automatically have that capture documentation just by voice? In a lot of the worlds today, those are individual pieces. We fundamentally felt that at the end of the day, these AI agents have to work in concert across that experience. So we actually worked to build one of the first, what we called a clinical copilot, what we built directly into Teams. This is all pre-pandemic. And that became so popular that what we decided to do was actually allow that agent to evolve across very distinct domains in healthcare to really drive the last mile. Those three domains, which will be apparent as you listen to what Mary's going to talk about, occur around patient observation and event detection and surveillance. The second domain revolves around workflow orchestration, because you always have to ask the question at the end of the day. It's one thing to be able to identify a signal. What do you do with it? Where does it go? What is the interaction? What is the next best action? So we wanted these AI agents to live and drive workflow for those clinical teams. And the third and final area was documentation. not necessarily to have to build, for example, voice-based and ambient documentation. There's enough players in that space, Nuance being one of them, but an ability to actually plug in large language models that can be role tailored. If I knew that I needed this specifically for physician documentation because it is a physician encounter, or this because this is a virtual nursing encounter and nursing documentation is fundamentally different. These agents help to drive what is the appropriate use case and what is the appropriate workflow that is required in context of care delivery. And so that is fundamentally what Andor started to work on over the last several years. Now, that same set of experiences, we're going to really just touch on one, right? Back then, this notion of distinct AI domains and an infrastructure to allow for that last mile orchestration, that was still relatively new to a lot of folks. They're still acquiring feature-based sets or building their own LLMs, so on and so forth, but not putting it in context of a clinical workflow. We actually felt that virtual was the perfect canvas to allow for these AI agents to actually operate. So when we came to market, the idea was to actually bring an entire AI agentified virtual platform, one that can be used in outpatient settings, one that could be used discreetly in inpatient settings around this notion of the virtual hospital, and in terms of how we manage patients even in the home setting. Now, we won't go through any of this today. We're only going to focus specifically on Centera, but I will at least touch on how Centera has been leveraging these AI agents to really drive a distinct level of care within their own institutions. Think about this again: observation, orchestration, and documentation. When we think about virtual nursing, this is the perfect area by which these domains really come to light. Oftentimes, and I don't know how many of you are CNOs or are doing anything in the virtual nursing space, the early days of virtual nursing suggested that if I just put a camera in the room, I can have a nurse dial in and I'm all good. And that's virtual nursing. And there's some ROI to that, right? But the reality is when you look at the workflow of that experience, fundamentally, bedside teams were still making phone calls to virtual nursing hubs. They're saying, I need you to pull up this chart. I need you to dial into this room or this particular cart. Oh, are you available? Are you not? So there was still quite a bit of this manual effort that exists to curate what is the event, what is the workflow, who is available, who's on shift that can actually dial into the room. This was the perfect area to leverage these AI agents. And so here, we've had this opportunity to now use AI agents not just to surveil events that are occurring within the EHR, but even allowing for agents to observe the events that are happening in the room or around the patient, events that could be coming from devices such as telemetry, as well as, for example, even devices that could be non-camera based monitoring, like LiDAR radar. But to use actually a combination of those data points to properly curate and raise very discrete events to the right clinical resource. But that right clinical resource is dependent upon a number of things. Who is the virtual nurse assigned? To what specific unit? What tasks do they have? Are they already at capacity to be able to do this? And do I need to move this event to a different virtual clinical resource? We let these AI agents manage the workflow to identify those blocks and be able to know where to actually send that so I can properly respond to those events in real time. Then finally, when I actually join into that room from a virtual nursing perspective, you allow these AI agents to support the virtual nurse experience. In this particular situation, I know this is the event, this is the workflow, and for the virtual nurse, I should also know these are the specific documentation elements or assessments for a virtual nurse that are required to be completed, but not have to type that out. I'm just going to have simply an AI agent listen to that conversation in the room and automatically document discreetly back into the EHR. Nursing is so fundamentally different in this space. Unlike the typical physician documentation, it's pretty linear in that regard. It's an encounter based at the end of the day. But in nursing, it is nonlinear. It's dependent upon the event. It's dependent upon the context. It's dependent upon what is happening with the patient that will dictate what is the documentation that is required relative to this event. That is why we required or needed all of those elements to come together in a very cohesive last mile experience. Now, to that end, this is a little bit of what Sentara is actually doing already today. Identifying very discrete events, raising those events to available virtual nurses assigned to these particular tasks, and then finally also leveraging the same technology once they dive in to these to have these AI agents actually help to capture documentation. Again, that's composable. It doesn't have to be my large language model, doesn't have to be someone else's large language. It could be one that is developed, for example, like Rich was talking about from Northwell. That's a behavior, not an infrastructure. You want this ability to be able to compose behaviors based on that workflow and that particular experience. But you need a platform or an infrastructure to do that. Where we're going for many of our organizations is far and beyond what you do with just EHR surveillance. Many of you who actually know about virtual observation and virtual sitting are already probably doing some of these types of things like motion detection, fall risk, so on and so forth. For the most part, if you're in this business, that's pretty tacit. If you don't do that, you probably shouldn't be in the business, to be very honest with you. But the reality is, even this type of modeling is actually old. It's obsolete. What we're doing today is actually identifying opportunities to either, one, augment the observational path and the observational agents by actually imbuing real-world ambient agents that could observe any event that's occurring in the room. Neural vision, as what many of you might understand. So imagine not having somebody sitting there watching the room, but imagine an AI agent that is watching the room, that can tell, for example, the patient hasn't moved in the last 2 hours, they're at risk for pressure injury. To be able to say, hey, by the way, this nurse that walked in the door is actually walking into infectious disease situation. They need to make sure they have the right PPE. Or, for example, that as simple as this particular room is clean and is ready for a new admit. Being able to identify throughput, clinical measures, letting these AI agents actually raise very distinct events that can be identified, again, not just from the EHR, but actually from distinct other data sources, when combined, give you the right alert and notification to the right care team member. This becomes fundamentally important as you listen to what Sentara is going to show you and talk about today. And also, one thing I want to mention is this is not new. Many of our organizations like Andor Health, as well as, for example, Medical University of South Carolina, one of 2 national telehealth centers of excellence, have actually published in peer-reviewed journals like New England Journal of Medicine, the ATA, where they are seeing these agents actually drive a distinct return on investment. That's also going to be important as we talk about this, because when you think about AI, it's great to talk about it. It's quite another thing to actually prove the value. Dr. Sadeghi, I think you mentioned that earlier, prove the value of what you're bringing to the table. We made it a point that these type of metrics should not come from a vendor. They should come from the customer. So everything that we've seen are published in peer-reviewed literature, such as Andor Health. They've saved over 3.5 hours per nurse shift per ward. That's actually consistent even with MUSC, where they've given back about 77 days directly to the bedside teams so that they themselves can actually provide a higher delivery of care, not focused on things that are probably left to be done administratively. Now, to punctuate that point, I want to go ahead and turn it over to Mary, because I hate the sound of my voice. And I'll allow her to kind of introduce herself and Sentara and a little bit of what they've been doing specifically in this space. Mary?
Thank you, Noel. And good morning, everybody in Microsoft. Thank you for allowing us the opportunity to present today. I've been with Andor, I'm their inaugural CNO, I've been with them. It'll be 3 months at the end of this month. Prior to that, I was the Enterprise Chief Nursing Officer of Centera Health, the largest healthcare system in Virginia. I think 20th largest healthcare system nationally. 12 hospitals, 4 health plans, a large post-acute ambulatory footprint. And I will share with you our journey and what Centera has learned and continues to learn, and the direction that they are headed in with a partner like Andor. And so moving forward, we were looking at, okay, what were the motivating factors? We know that nationally we've got an issue with nursing shortages. And it isn't just nursing. We have physician shortages. We have respiratory therapist shortages, patient care technicians or nursing assistants. It wasn't specific to nursing, but nursing being 2/3 of the workforce in the acute care setting, and it was a pain point. At the time in Centera, and this is around April of 2023, when we really committed to looking at virtual nursing. And I always said it wasn't just nursing, it was virtual nursing and care, because it should impact across other disciplines, though nursing being a big piece of it. I was sitting on about 800 acute care RN vacant positions. And we were using external travelers. We had internal travelers, and there is, that's a cost to the organization. So trying to solve for that vacancy, we use turnover as an ROI metric because there was very little out there in the literature. In the last couple of years, we've seen a lot more from places like Andor Health, Medical University of South Carolina, publishing data around other ROI metrics. The turnover in Centera, RN turnover, was only 12.5%. The turnover within years 1 to 3 was around 55%. So being able to, really focus, but, we were asked to follow what was going on, what we were seeing in the literature at the time. We also were challenged with throughput, length of stay, no different than any other organizations, and really looking at how could we leverage, and I'll admit I was skeptical. I was also caught up initially in the cameras and the televisions, because it was like I could see it. It was tangible. I quickly learned it was about the AI and where could AI take us. And Noel hit on this a little bit. Centera, no different than other healthcare systems, a lot of carts, a lot of, disparate technologies used to take care of patients, having to go find a cart, bring it into the bedside for sitting, for example. That was Centera. We decided we were going to build our own. And with that, it was very problematic. And there was no AI. It was really physical people looking, watching. And so learning that AI was really going to be the leverage that was going to be a game changer. And so, looking at, okay, what are the core KPIs that we could actually measure and say there was an impact? So I mentioned turnover only because it was something in the literature at the time, and we knew cost of turnover. We used 70,000, the cost of turnover of an RN. We were going to look at length of stay. Could we decrease or increase the number of discharges by 1 p.m., which frees up those beds? Down the road, what else could be leveraged to bring, high-risk double checks to the bedside, mentoring to the bedside? In fall of 2023, I met with across the 12 hospitals, 1,000 bedside RNs. And I had 4 questions. My 4th question was, so what do you guys think about virtual nursing? And I got a lot of deer in the headlight, a lot of people looking at me like, I don't even know what you're talking about. And so I would just say, how many of you FaceTime with friends and family? So this is FaceTime on steroids. Not even talking about the AI piece, because it had to be something that was more tangible for that bedside nurse. The key was removing administrative burden. So I asked them, hey, you guys, if you could bring a nurse, an experienced nurse into the room as a virtual presence, what would you want them to do? And at the time, most of our hospitals had admission discharge nurses. And they said, admission, discharges, and patient education, and that's not unique to Sentara. All of us, and the truth is, the patient education, check, 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 check. And on patient experience, Sentara is a Press Ganey shop. It was an opportunity for us. And I will share with you that in our ambulatory environment, our physicians and providers were seeing that gap around education. We were seeing it in readmissions as well. So when the nurses said, we really would like to focus on that, myself and the VP that was assigned to this to implement it, we wanted to do the mentoring and the high-risk med checks and to provide that support to impact that first, second-year turnover rate. But in the end, it was about because I needed that buy-in. And if it's driven by frontline nurses, you're going to get better acceptance. So we then started going, okay, who are our vendors? We were looking for a partner that was the equipment agnostic. Super important because we had, we were using cameras that we started with a company in 2016, then started building our own. So what happens when those cameras break? We weren't a camera manufacturing organization, but our IT was, they felt they could build this and it became very problematic. And when you need a cart, having to go look for it, now you're taking nursing time to go get something. And we had a limited number across the 12 hospitals. So looking for a partner that could innovate with us. So equipment agnostic, EMR agnostic. We wanted to leverage big Epic shops. Sentara was an early adopter of Epic. Looking, and that ambient documentation, nursing documentation was key. And so just in terms of a timeline, earlier, the panel this morning talked about speed to value. We were looking for a partner where we said 12 hospitals, 1,700 beds, 12 months. And Andor was like, got it. So Sentara went live in November of 2021. A very prescriptive process. We went through RFP. Myself and my VP, we went and did site visits, talking to frontline nurses about their vendor. If it left tomorrow, would it matter? And that was very important to us. And so we narrowed it down, and around May, we selected Andor as that partner. Virtual nursing is just the start. Again, an enterprise partner. Could we leverage the AI to create seamless care? It was one of the imperatives, personalized care, seamless care. And could I bring in a health plan chronic care manager to the bedside virtually at discharge, do a warm handover with the patient, because that's what makes a difference to those patients. It's not, we know there is what we call member abrasion with all the post-hospital follow-up calls that have to be made, and that people don't answer the calls. And so very quickly moving through 2023, right now, Sentara has about, as of yesterday, 844 beds live on virtual nursing. They went live yesterday on the ambient nursing documentation. And again, it's to remove that administrative burden. It will evolve over time. Mentioning the ROI, and of course, there was a lot of pressure. They wanted to see it within, 6 weeks. Whereas it doesn't work like that. This takes time to get the data. You've got to collect that data. There is directional data. The discharges by 1 p.m. went from 10% to 17.5% just in a small cohort of beds early on. Increases in the patient education. We all know HCAHPS changed their questions in 2025. So being able to do a comparison to 2024 and previous years makes it more challenging, but they have seen an increase in their patient education scores. Sentara, soon to have 11 magnet designated hospitals, very important for that magnet designation with, and being able to leverage things like falls with injury is something in terms of an ROI. That's real money, that's patient harm. So Kristen from MedStar with that safety component, very, very important, particularly leveraging eventually that observational AI to, I think, impact patient safety as well as staff safety.
And I think one thing I want to make mention of here is that what Sentara is actually doing, just stemming from what the earlier slide that she was talking about, they did a great job of being very specific about the KPIs they wanted to identify. At the end of the day, you still have to be accountable to the finance and the fiduciary side. Here, we've been able to actually identify for every hour that is saved, how much is in cost has actually been saved per hour. Also, on the other side, talking about length of stay and early discharges, this identification of how many more patients can I discharge even an hour earlier. That means that I can actually get another patient in the bed. You can actually put a number to that specific hour. And so for them, it's very specific in how they've been able to drive certain metrics relative to that.
And I do want to mention that this was not about reducing FTEs. That was a concern expressed by the nursing staff. And I did say to the CFO at the time, I said, Rob, this is not about, because when we went up on Epic, we eliminated all the unit clerks. Big mistake. This is back in 2008. And this wasn't about eliminating, it was about removing administrative burden to give time back to the nurses at the bedside to focus on those things that make their work more meaningful, purposeful, as well as focusing on those safety behaviors. And so, again, that takes time. They will finish at the end of October this year. And, we will have more data that will be shared. It will be published, but really focusing on and there was never a pilot. It was never going to be, we'll see if it works. It was, we are going to do this because we have to. There was no other solution to fill those vacant RN positions. So it was always FTE neutral. So as of yesterday, Sentara, with those hospitals that are live, have been able to give around 3,000 hours back to the bedside nurses in those hospitals where virtual nursing is live. And that equates to, what do we say, about 125 days back to those bedside nurses. Because that is what frustrates nurses at the bedside, not having the time. And again, early increases in patient education, patients actually like it a lot. In that timeline, we had to go through AI governance, all the legal, all of those types of things were things we had to learn and work through. And early communication externally about virtual nursing, early, I'm talking fall of 2023, we hadn't even selected a vendor yet. We started talking about it because it was going to get out there into the press just through Facebook. And so external, internal communications, very important. So your public knows what's going on as well as your staff.
I know we're coming up on time here, so we're just going to close up with a couple of thoughts and obviously want to continue the conversation with Mary. She'll be here for the next couple of days, but I'll just punctuate a couple of key points. Again, when you look at what some of these health systems are doing, understanding, for example, who are they doing it with? How are they doing that? There should be a consistency across their partners and what kind of return on investment is actually coming to bear. And so, as you can kind of see, we really lean on our customers themselves to actually publish their own results, publish exactly what they're doing and have it peer reviewed. Because as we move forward in this realm of AI, it has to be more than just what the vendor brings to the table, right? It has to be what is actually practical. what is happening? What am I actually driving in that organization? So as we go forward, just something to be thoughtful of as you go in your own AI journeys. Be specific about what you're trying to value or place value upon, and ensure that there's a consistency in those results as you move.
Great talk. Thank you. I was curious from the virtual care nursing virtual care perspective, and you mentioned you're not looking to reduce headcount, but are you also, was the strategy also to try to retain these senior nurses who are planning potentially for retirement, want to get off their feet, but you still can leverage them now in this virtual capacity to help support the newer nurses in their journey as well, too?
Absolutely. And that will be the evolution of the model. We were very purposeful that a nurse had to have 5 years of current experience to be a virtual nurse. The physicality, and we were hoping, and we did see nurses that had left the bedside coming back to do the virtual nursing. Right now, there are about, I think, 25 virtual nurses in Sentara. They will move to 55 once all the hospitals go live. So it really, and then you start to think about how do you build on that? And it is to tap into those nurses that are leaving the bedside to retain that expertise. I do think there's a huge component for supporting the younger nurses in terms of experience. As we know, COVID greatly impacted their education. And I think that's also why we're seeing such significant turnover in the 1 to basically 3 years. It's not unique to Sentara. Everybody's struggling with that turnover.
I think that conversation is changing in the industry. I think it started with, can I improve ratios? Can I reduce headcount? Because that's finance what finance want. But when you start digging in, the reality is that they can't even find the nurses. I mean, if we
there's a youth shortage. You've got a lot of folks who are retiring.
Exactly.
Yes.
And not replacing them fast enough.
And we can't produce them fast enough. And it's true for physicians, for respiratory therapists. I mean, Sentara is looking at a virtual hospitalist model, looking at a virtual respiratory model. And you start to think about, your head starts to explode when you think about all the things that you could bring in virtually. Because right now, woundostomy nurses, they spend time moving between rooms. They lose time. Not every hospital has them. They're not even available 24/7. And what you really want to do is to leverage them when needed. And so, the use of med history techs, virtual. So Sentara uses a hub approach where they're all co-located. And so the next evolution will be sitting with Andor, eventually telemetry, centralized telemetry, because there is some major safety opportunities there leveraging AI. But yeah, it's not about reducing the number of nurses at the bedside.
Mary, thank you so much for joining us.